Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine a patient who becomes agitated, sweaty, tachycardic, and febrile a few hours after an antidepressant dose increase. On examination, there is tremor, brisk reflexes, and inducible ankle clonus. The key question is whether this is serotonin syndrome, neuroleptic malignant syndrome, anticholinergic toxicity, or another hyperthermic emergency. Serotonin syndrome is an acute state of excessive serotonergic activity. It produces a characteristic triad of neuromuscular hyperactivity, autonomic instability, and altered mental state. To understand the syndrome, think in 4 boxes: the drug trigger, the underlying mechanism, the characteristic clinical clues, and the immediate management. First, consider the mechanism. Serotonin is an excitatory and modulatory neurotransmitter involved in mood, arousal, autonomic function, motor control, pain signaling, and gastrointestinal activity. Under normal circumstances, its release and reuptake are tightly regulated. A serotonergic drug is introduced, its dose is increased, an overdose occurs, or 2 interacting drugs are combined. This leads to increased synaptic serotonin, followed by excessive stimulation of central and peripheral 5-HT1A and 5-HT2A receptors. Excessive receptor stimulation then causes motor neuron hyperexcitability and sympathetic overactivity. Motor neuron hyperexcitability produces clonus, hyperreflexia, tremor, and rigidity. Sympathetic overactivity produces agitation, sweating, tachycardia, hypertension, and hyperthermia. Common triggers include selective serotonin reuptake inhibitors, serotonin and noradrenaline reuptake inhibitors, monoamine oxidase inhibitors, and tricyclic antidepressants. Other important drugs include tramadol, linezolid, lithium, triptans, fentanyl, methadone, dextromethorphan, and St. John's wort. Recreational drugs, such as MDMA, can also cause severe serotonergic toxicity. The highest risk situations often involve combinations of drugs that increase serotonin through different mechanisms. A particularly dangerous interaction is the combination of a monoamine oxidase inhibitor with another serotonergic agent. Now move to the clinical presentation. Serotonin syndrome usually develops rapidly, often within hours of starting a drug, increasing a dose, taking an overdose, or adding an interacting medication. This rapid onset is an important diagnostic clue. The neuromuscular findings are especially valuable. Look for inducible clonus, spontaneous clonus, or ocular clonus. Hyperreflexia and tremor are common, and some patients develop increased muscle tone or rigidity. The hyperreflexia and clonus are often more prominent in the lower limbs. The key clue is clonus in a patient with an appropriate serotonergic drug history. Among all the clinical findings, clonus is one of the most useful discriminators. Autonomic overactivity causes diaphoresis, tachycardia, hypertension, fever, dilated pupils, and diarrhea. Diarrhea is useful because it reflects increased gastrointestinal serotonergic activity and can help distinguish serotonin syndrome from conditions that reduce gut motility. Mental state changes range from anxiety and restlessness to marked agitation and confusion. Severe toxicity may progress to seizures, coma, profound hyperthermia, and multi-organ injury. The clinical features become easier to remember when they are linked directly to the mechanism. Serotonin excess leads to spinal motor hyperexcitability, which produces clonus and hyperreflexia. Serotonin excess also leads to sympathetic overdrive, which produces sweating, tachycardia, and hypertension. Sustained muscle contraction then generates heat, causing hyperthermia. This last point is clinically important. The hyperthermia is mainly caused by excessive muscular activity rather than an increased hypothalamic temperature set point. Antipyretics, such as paracetamol, therefore do not treat the underlying problem and are generally ineffective. Diagnosis is clinical. There is no single blood test that confirms serotonin syndrome. The diagnosis depends on recognizing the combination of a serotonergic drug exposure, rapid onset, and characteristic examination findings, particularly clonus and hyperreflexia. Investigations may still be required to assess severity, identify complications, and exclude alternative diagnoses. These can include renal function, electrolytes, creatine kinase, liver tests, blood gases, and an electrocardiogram, depending on the clinical situation. However, treatment should not be delayed while waiting for test results when the clinical picture is convincing. Do not confuse serotonin syndrome with neuroleptic malignant syndrome. Neuroleptic malignant syndrome usually develops more slowly, typically over 1 to 3 days, following dopamine receptor blockade or withdrawal of dopaminergic medication. The characteristic motor abnormality is generalized lead pipe rigidity. Reflexes may be normal or reduced, and clonus is not a typical feature. By contrast, serotonin syndrome usually develops within hours and causes hyperreflexia and clonus, often most obvious in the legs. MRCP trap. Severe serotonin syndrome can produce marked rigidity, which may obscure the underlying clonus and hyperreflexia. The drug history and rapid onset therefore remain essential. Another differential is anticholinergic toxicity. Both conditions may cause agitation, tachycardia, fever, and dilated pupils. However, anticholinergic toxicity causes dry skin, dry mucous membranes, urinary retention, and reduced bowel sounds or ileus. Sweating is absent. Serotonin syndrome usually causes prominent diaphoresis and increased gastrointestinal activity, including diarrhea. Malignant hyperthermia is associated with exposure to triggering anesthetic agents or succinylcholine. It causes severe rigidity, rapidly rising temperature, and increased carbon dioxide production, often presenting with unexplained hypercapnia during anesthesia. The first treatment step in serotonin syndrome is to stop all serotonergic agents immediately. Most patients then require supportive care, give intravenous fluids when indicated, provide oxygen, monitor the cardiac rhythm, and correct electrolyte or metabolic abnormalities. Benzodiazepines are central to treatment because they reduce agitation and muscle activity. Less muscle activity means less sympathetic stimulation and less heat production. Benzodiazepines are therefore useful not only for calming the patient, but also for addressing the mechanism of toxicity. Avoid unnecessary physical restraint where possible because struggling and sustained muscle contraction can worsen hyperthermia and lactic acidosis. For severe hyperthermia, use active external cooling, adequate sedation, and aggressive supportive care. Patients with extreme temperatures, severe rigidity, or clinical deterioration may require intubation and paralysis with a non-depolarizing neuromuscular blocker. A non-depolarizing agent is preferred because succinylcholine may be problematic when severe muscle injury and hyperkalemia are present. Cyproheptadine may be used in moderate to severe cases when supportive measures and benzodiazepines are insufficient. It antagonizes serotonin receptors and reduces 5-HT-mediated toxicity. Because cyproheptadine is given enterally, it may need to be administered through a nasogastric tube in an intubated patient. If you remember one thing, remember this: rapid onset after serotonergic drug exposure, together with clonus and hyperreflexia, strongly suggests serotonin syndrome. Stop the offending drugs, control agitation and muscle activity with benzodiazepines, and treat severe hyperthermia as a medical emergency. Quick recall. A patient develops fever, agitation, and rigidity 2 hours after linezolid is added to a selective serotonin reuptake inhibitor. Examination shows diaphoresis, brisk leg reflexes, and inducible ankle clonus. What is the most likely diagnosis, and which examination finding is the strongest discriminator? The answer is serotonin syndrome, and the strongest discriminator is clonus in the appropriate serotonergic drug context. A severely unwell patient with serotonin syndrome has a temperature of 41 degrees Celsius despite receiving paracetamol. Why is the antipyretic ineffective, and what immediate treatment principle is required? The answer is that the temperature is being generated by sustained muscle activity rather than a raised hypothalamic set point. The patient requires rapid control of muscle activity with sedation, active cooling, and, when necessary, intubation and paralysis using a non-depolarizing neuromuscular blocker. Do subscribe to the channel for further videos.